And now we will turn it over to our own wonderful clinical expert, Mary Blankson. Thank you so much, Mary.
Thank you so much, Chris, and just really excited to talk to you guys today about my favorite topic, which is team-based care. So you can go ahead. So we're going to talk a little bit about just interdisciplinary team-based care and some general tips and frameworks for effective chronic disease management. My hope is that through these few examples, you'll have the opportunity to kind of have some larger framing for the ways that you hone your interventions and try to make them more successful. Next slide. So the three items we're going to talk about stratified solutions. So it's sort of the ultimate multitasking when it comes to chronic disease management and making sure that you really are addressing as many sections of your population at the same time without necessarily overburdening the members of your team. Next, we're going to talk about scripting your language and proactive communication with your teams to make sure you're getting what you need from the members of your team. And then lastly, we're going to talk about that by any means model and really think about other alternatives to kind of closing care gaps outside of sort of your traditional, I'm a patient and I show up for a medical appointment and have my care gap closed as a part of that visit. So next slide. So first, we're going to talk about stratified approaches to chronic disease care. So what I mean by this is really thinking about, instead of just saying, okay, we're going to focus on this one population and think about how we're going to affect change in that population with one intervention, how do we maybe consider our population and check to see, are there obvious groups that can be looked at separately to ensure that there's a best fit solution? So I know many of the project teams that we've been meeting with and talking with, we've helped you to kind of stratify your group so we can look at uncontrolled hypertensive patients, either that maybe are on no agents or folks that might be on a single agent, or maybe those that are on 2+ agents. So that maybe is one sort of specific separation. And then we want to think about what are the specific solutions that could be employed for each group, right? Because it's not going to be the same intervention for somebody who's on no medications as those, for example, who maybe are already on 2 or 3 agents. The intervention might look vastly different. And then step 2, you really want to think about and consider your team. So who are the members of your team? What types of team members do you have at your disposal on your team to really support improving hypertension control, as our example today? So are you able to allocate team members to different groups as kind of who is going to accomplish the work for that particular group? And your attempt is going to be to try to only assign each team member to a single group. So again, making sure that we're not making or overburdening our team members, but really thinking about which group will this particular team member be the most successful at affecting change with. And then what strategies do you have already built into your processes at your health center or at your clinic to think about accountable practice, right? So how do we give meaningful clinical data, not just to providers, but to your medical assistants, to your nurses, to your pharmacists, and to other team members so they can really see the impact of their actions. So that's really kind of your step 3 is thinking about that evaluation. Next slide. So when we think of the role of MA, the things we tend to think about are planner. So things that are algorithmic, clearly supported by the evidence. There kind of is a one way to do things. There's not a lot of creative thinking that's involved other than trying to figure out how to mitigate barriers and how to kind of utilize facilitators that might be present for the patient to accomplish the task at hand. Delegated referral, so making sure that there is no gatekeeping for your team members to be able to make referrals, whether that's to the dietitian for smoking cessation, maybe for a group, or whatever the case may be. And then lastly, kind of the population health or panel management approach to closing care gaps. Next slide. I put a couple of just examples in the slide deck. So when you get them, so this is our planned care dashboard, or sort of our huddle dashboard. And you'll notice there, for example, the cardiovascular statin med is a reminder for our medical assistants as a part of the medical visit. And you're probably wondering, what does a medical assistant have anything to do with prescribing a statin or not prescribing a statin? But our medical assistants, when they look at this dashboard, they're going to recognize that that patient, there's a specific action that the medical assistant has to do to remind the provider to evaluate the need for a statin. So next slide, let's take a look at that. So when you look at the progress note, you'll notice in the chief complainer under the reason for the appointment, the patient is actually here for pre-op surgery, but there's other notes under the visit. So for example, the patient is in need of nutrition education as a part of diet and exercise counseling. The patient might need hepatitis C screening or other actions. So in here, the medical assistant would actually write, patient needs evaluation, please start statin medication or document a contraindication. Next slide. So here's just a print screen of our job tool that actually goes along with our dashboard. So you'll see sort of the statin measure is the second one on here. And again, I included this screen print mainly for you to just have an example of how to sort of better structure and create job tools that help everybody to know kind of what's your work and then what's the work of your team member. So for example, here for the statin measure, the medical assistant is going to know in green, it's my role to make sure that for this particular patient that I'm documenting their blood pressure and vital signs section. And then I'm adding to the chief complaint, CVD risk and statin, if appropriate, for the provider follow up during the visit. So when that provider actually logs into that progress note, instead of sort of magically having to remember among the other chief complaints that brought the patient there that day, there'll be a note reminding me that I need to consider that. And under the provider responsibility, you see that the provider either adds a current medication or statin and or documents a specific contraindication in the allergy section, which will then sort of make the data count or actually, remove that item from our dashboard. Next slide. Now thinking about the role of the nurse, again, I put this in here as a reference slide to think about sort of standing orders versus delegated orders. So this is a good definition for you to use. Standing orders being a policy that gives a very structured list or algorithm for a nurse to follow to be able to conduct any type of care for your patients. And a delegated order being a specific order from a specific provider for a specific patient. Next slide. So when you're thinking about kind of the role of the care team in a stratified approach, the global goals of that is first to not tax any one team member, but to utilize every set of hands and feet to move more rapidly in the desired direction, right? Otherwise we just feel like our bandwidth is too low and we can't possibly accomplish everything. We also want to ensure that every group gets attention, right? And that there's a more specific intervention to increase the impact for that particular group. So in the example that we used before, focused on sort of the 3 groups in our hypertension group, those on no medications, those on 1 agent, and those on 2+ agents. For group 1 on no medications, maybe the intervention is actually an RN or a pharmacist, or both potentially in a co-visit, assessing blood pressure in the office, prescribing via standing order an SMBP, and then starting a medication for the patient if applicable. Utilizing a standing order that shows what are the first agents that should be started for these patients. The nurse may then schedule a virtual visit 2 weeks later to confirm that the patient's having no problems with their medication, no side effect, they didn't have any problem getting it from the pharmacy, and also to confirm that they're using their SMBP, they're doing their self-monitored blood pressure, and the nurse can actually collect that data. And then coordinate follow-up with the PCP 2 weeks later. So the PCP doesn't necessarily have the burden or get involved directly, except for signing off on the use of the standing order kind of in general in the organization, and then when the patient follows up after starting that first agent. Next slide. Our second group, which is our single agent group, might look like this. Maybe there's a medical assistant to work to get these individuals in the office with the PCP for evaluation to ensure that there's an accurate blood pressure reading with a repeat to make sure that we really are determining are they uncontrolled or not. And then they're going to prompt in the chief complaint PCP to add second hypertension agent, and the PCP then adds the agent. And then, of course, a repeat BP check with the RN or the PCP to ensure that the patient has achieved their goal. So again, sort of a different group of individuals sort of involved with that intervention with that second group. Now thinking about what a stratified intervention would look like, sort of adding the next group, which would be those folks who are still uncontrolled on 2+ agents. We would want to think about allowing potentially huddle time for a centralized care manager to review the list and determine who may benefit from PCP management versus possibly an e-consult, maybe to a cardiologist a primary care specialist or nephrologist or pharmacist, maybe for hypertensive management. And if the PCP, then the MA can coordinate or schedule a visit. But if there's a need for the e-consultant, that care coordinator or care manager centrally can actually go ahead and complete that centralized referral and then implement the suggestions from the e-consult. So if you think about it, it's sort of 3 different groups of individuals leading a different process, but allows your health center actually to have a bigger impact because it is actually impacting all 3 groups, but utilizing different members of the care team. Next slide. I just put an example in here of our performance appraisal scorecards for our medical assistant. So as you think about kind of evaluating success of that too, really think about how you give meaningful feedback to your team members. So for us, we give them a score, we compare it to their site average and also to their agency average. So I get a sense of how well is the overall site performing, as well as how is the individual performing. Next slide. Proactive communication as a part of this is making sure that you're providing scripting to train your teams to use specific asks when communicating with a provider. So again, just as an example for the nurse, report what you've done. Provider, I sent the prescription for the SMBP cuff. I've started lifestyle modification with smoking cessation and also referred to an RD to begin work on salt reduction. And then deliver your specific language as to the ask that you have for the provider. For folks on no medications, which medication would you like to add? For a single agent, which medication would you like to add? So same message, right? For 2+ agents, would you like to add a medication or would you like me to coordinate an e-consult or referral to cardiology? So again, it's sort of taking the guesswork out of it for the PCP and saying, I as the nurse already know this is the plan, this is what the evidence says, this is where I'd like to go next. Provider, which one, what would you prefer? All I need is this information and then I can continue to move the ball down the lane. Next slide. So now as we think about this by any means model, this is a picture of what we call our BAM dashboard. And as you'll see on the left-hand column, we are a multi-site organization. So this is a list of all of our sites. And then you'll see numbers kind of by day. And what this does is this actually identifies patients who are coming into the health center for a service outside of the medical department, but who are due for medical care gaps. Next slide. So we have LPNs who are actually assigned to close these care gaps. So what they'll do is you'll see in these 2 examples, this is for the Middletown site location. If I were the BAM LPN in the Middletown location, I would click on the number. And if you see on the left-hand side, you can see that, these 2 examples, these are patients who have appointments in Middletown Dental. I have the time of the appointment. In the part that's blacked out is the provider that they're seeing in the dental department, as well as the patient's ID number. But then if you look on the list, I can actually see what are the items that this patient is due for. So specifically for the hypertension metric, I can see when was the last time we took their blood pressure and what was the reading. And of course, because of my training, I know that anything over 140/90, I'm going to need to get a repeat blood pressure. So I can tell how high were they on their last measure. Is this somebody who's just marginally uncontrolled and I just want to take a very careful measure? Or is this somebody who I likely may have uncontrolled hypertension and may need more medication? Next slide. So of course, with anything that we do, there are potential points of friction. So whether that's space for your care team members to have their visits or to have their interactions with patients, kind of this discussion of sort of gatekeeping or top of license practice where the PCP really wants to sign off on every little individual action. And also kind of this idea of the value of the art of medicine versus just kind of an evidence-based algorithm. And really kind of that friction between the 2 and understanding when is art a part of it and when is it really just an algorithm. Next slide. And of course, managing your culture. So here's just some tips and tricks that I just encourage everyone to use with regard to your team-based model of care. So making sure that your team-based model of care and your whole culture and environment is really based on the value of every role, not just talking about everybody as if they're a downstream catch-all for providers to improve provider retention. They're a valuable member that really has good skills to contribute to the bigger picture that can actually help the provider to be a better provider and to have greater success in managing these complex pictures. And then another one that I'll just point out is kind of normalizing feedback as a part of practice improvement, right? Creating that measurement culture where I don't see it as punitive when you tell me that, I'm only doing this 67% of the time, but there are missed opportunities, and how do I improve my own practice? So I'm hopeful that you can think about some of these interventions and think about how maybe some of the current work that you're doing, these could actually help you to sort of up the ante and up the impact, so that hopefully you can have even greater success in what you're doing. So Chris, I'll turn